So at World Lung meeting in 2019, I've had the privilege of presenting a paper looking at the association of tissue TMB, tumor mutation burden, and its correlation with response, progression-free, and overall survival in the context of chemotherapy alone as well as chemo combined with pembrolizumab in the first-line therapy of metastatic non-squamous non-small cell. The bottom line, there is no overt correlation, at least based on our analysis. By way of review, 021 was a large multi-center phase 1, phase 2 trial looking at pembrolizumab in combination with various cytotoxic regimens as well as other immunotherapies such as ipilimumab, both in the first and second line setting. So it was essentially a basket study looking at various clinical venues and the role that pembrolizumab might play in those venues. Cohort C of that study specifically assessed pembrolizumab in combination with pemetrexed and carboplatin. Pembro is given at either 2 or 10 mg per kg every 3 weeks along with the chemotherapy, and continued for up to 2 years in patients who had no disease progression or unacceptable toxicity. And pemetrexed was continued as maintenance therapy indefinitely in the absence of progression or untoward toxicity. Cohort G was much larger. This was a randomized phase 2 study comparing chemotherapy alone, in this case pem-carbo, to the triplet combination of pem-carbo and pembro, with the same caveats. Treatment with pembro continued for 35 cycles or 2 years, and pemetrexed continued as maintenance. The one major difference, the salient difference, is pembrolizumab was given at a flat dose of 200 mg every 3 weeks. So some difference or a deviation from the original cohort C. It was in this group that we observed a major improvement in overall response rate and progression-free survival that ultimately led to a conditional approval for the triplet combination in metastatic non-squamous non-small cell in the United States, and also laid the groundwork for the much larger randomized phase 3 trial of pem-carbo or pem-carbo-pembro in non-squamous, which has now led pretty much to a worldwide approval for this triplet in non-squamous, independent of PD-L1 status. There's been tremendous interest in TMB as a potential marker for efficacy, and so this was a pre-specified, fully completed analysis before the clinical data were available, assessing TMB by whole exome sequencing. So it's not, TMB has been often considered a surrogate for neoantigen load, and this was actually probably a better way of defining it using WES or whole exome sequencing as opposed to next generation sequencing, which may really just be a surrogate for that approach. Of the 147 patients who were in those two arms, we ultimately had sufficient tissue and analysis and outcome data in roughly half, about 70 out of the 147. And it's in that group where we conducted the analysis. So it is a prospective assessment of tumor marker with an exploratory correlation in the context of clinical data. And the bottom line is it was not predictive. Neither high nor low TMB seemed to correlate with response rate, with progression-free survival or overall survival. Chemotherapy in combination with pembrolizumab was superior to chemo alone regardless of TMB status, and there did not appear to be any correlation whatsoever between TMB and PD-L1, which we've observed previously in other studies, including the Checkmate 227 trial. When we look at ROC curves, the curves themselves are close to midline, indicating that this is probably not a good predictive marker for outcome. And it really is sort of the appetizer, so to speak, for the much larger secondary analysis of Keynote 189, which is being presented by Dr. Garasino at the same meeting, and which, parenthetically, also shows no overt correlation between outcome and TMB. So I think TMB, or the potential role of TMB, might be much stronger in immunotherapy combinations such as ipilimumab with Nivo, and may not have much predictive value, at least in the context of chemo alone or chemo plus checkpoint inhibition. TMB, I believe, still has a role when it comes to biomarkers, but it needs to be defined further. I suspect there is a population that has no PD-L1 expression and low TMB, where frankly, checkpoint inhibition may have no role whatsoever. If you look at the secondary analysis of Checkmate 227, in that population, this is folks who got chemo alone or chemo plus Nivo or the Ipi-Nivo combination. Frankly, chemo alone did just as well with respect to response and progression-free survival. In fact, there may have been an early survival decrement for the those getting Ipi-Nivo. On the other hand, there are some new markers, STK11, LKB1, which you do find on next-generation sequencing. It's one amongst many of the mutations that seem to emerge for which we don't really have any targeted therapy as yet. But intriguingly, there's been a strong correlation in that group that adding pembro to chemotherapy does not improve outcome. That unlike a group that is wild type for STK11 and LKB1, where patients clearly do benefit from the addition of checkpoint inhibition to chemo, this group does not appear to benefit. And I think it's important. Willy-nilly, we've been using checkpoint inhibitors at least in the last 2 to 3 years, in virtually all of our patients who appear to be eligible. And clearly there are some who do not have any clinical response. In some cases we see hyperprogression, and I think it's critically important that we be able to figure out which populations are more likely to benefit and which populations where we need to explore alternative strategies. This group may be better served by chemo plus angiogenesis inhibitors or other targeted agents.